Good morning, everyone. Welcome to 90th DMA IMA NDB Meet. We have with us Dr. Nidhi Dhawan. She is an Associate Medical Director of ENT and Head of the Safety Committee, Shroff Charity Eye Hospital, Daryaganj. Over to you, ma'am.
Thank you so much, Ritu. We are going to miss Dr. Meenakshi today, but due to some personal reason, she could not make it this morning. The last week has been a very dramatic week as far as the COVID situation in the world is concerned. Ritu, could you please pin my video? And it has been dramatic for a lot of reasons. Let's see. Can you see my presentation?
Yes, ma'am, but not in.
It is in the play mode only. Let's see. Okay, so it has been a very dramatic last week because one by one, most countries are opening up and declaring the pandemic over. कहीं कहीं मास्क मैंडेट खत्म हो गए, कहीं कहीं RT-PCR pre-travel nahi chahiye. At least locally, people are moving into those, governments and populations are moving into those zones of administration where they're declaring कि अब तो ये खत्म है. So in all probability, we can say that Omicron की वजह से the herd immunity or whatever that means has been achieved much faster than anticipated. And अगर उसको रोक ही नहीं सकते तो बाकी की सारी चीजों को करके फायदा क्या है? Is the reason that most people are following these guidelines. So I would say that in all probability, we can consider that the pandemic is on its way out, but the COVID per se is still not. So we'll try to connect the dots today, look at what is the world scene, and in today's discussion, we will talk about basic pathology and why is it that things that we are seeing clinically are happening. So global scenario, India update as we usually do. We'll also do a Sutra uptake, which is our homegrown Omicron modeling. And then we will move on to the pathology. What is the cellular and molecular basis for the clinical picture we see? And what is it that we can do as clinicians to mitigate the situation? So going by what has happened in the last 1 month, UK, US, Israel have both all three seen remarkable numbers. India saw very big numbers, but अगर हम उसको context में देखते हैं, तो these numbers appear very small in the global context. We were expecting much huger numbers. In all probability, we are seeing smaller numbers because of the relative asymptomatic or so-called clinically mild disease. We may not be counting all cases. They may not all have been tested. But if you see 10th of February, India's number has already dropped to around 60 and per million. And this is very encouraging as we see the wave also is largely come down. The R value, if we look at it, this line is 1. So anything that falls below this line is on its way out, infecting less than one new person per case. UK is hovering around 2, Japan around 1.5, but all others are on their way down. So if I magnify just that last part of the focus area, you see that everybody's graph is kind of coming down, but India and US have crossed that one. Israel is hovering around it. This means that at least in some countries mein, the Omicron is now not at threatening levels. So looking at the Omicron share, Israel 100%, UK 100%, India 99%. And you know that 1% which is persisting, so we are still seeing some delta. That little blue sliver is delta. US similarly delta. South Africa, if you remember, पहले Omicron 100% था और अब थोड़ी सी री-इमर्जेंस ऑफ डेल्टा है. Why that is so? It shouldn't be. Maybe this is a reporting artifact, because from all studies that we see, Omicron gives back immunity and does not allow Delta to infect. So it is actually sterilizing for Delta. So this should not be happening. But this is something that we have to watch and figure out what is happening here. Japan never really went to 100%, if you remember. Japan में थोड़ा सा ये हमेशा से डेल्टा रहा है. If we look at the case fatalities, so जो डेल्टा वेव में रही हैं उससे बहुत कम है. And if we look at the numbers, जो डेल्टा वेव में रहे हैं उससे बहुत ज्यादा है. Case numbers are much higher than what was in the Delta wave, and fatality is much lower than in the Delta wave. So in the clinical picture, we can say that Omicron has treated the populations it has infected rather well, but the sheer numbers make it a variant of concern. So what is the vaccination situation? Now, if we go back to what is happening the world over, abhi bhi about 60% of the world population has received one dose. Nearly 10.5 billion doses have been administered globally, and nearly 30 million are administered every day. This number, 10.6% of low income. So this has been rising from 2 to 4 to 5 to 6. Then it hovered around 6, 7. It has only now come in double digits. But if you look at the map, the African subcontinent is largely uncovered with vaccination, and the rest of the world is fairly well covered with it. So there is no vaccine equity even as we speak now. And this we are talking about a year and a half into vaccination. Interestingly, there are now some studies coming about, which is a matter of slight concern, कि जब से वैक्सीन रोल आउट हुआ है तब से ज्यादा वेरिएंट्स की इमर्जेंस देखी गई है. So this is the vaccine rollout in the world, and you see all the variants have emerged in this time frame. उससे पहले डेल्टा की आर्म शुरू हुई है, बट वैक्सीनेशन के बाद things are kind of speeding up, which is expected also. I mean, the virus will survive only if it can create evasion of the fight that we give it. which it's doing a good job of. So if we look at what is happening in terms of new cases emerging, जो unvaccinated area है, जहां पर ivermectin है, वहां पर आप देखो it is fewer new cases, to less than half new cases of what we have seen earlier. And if you look at these red areas, they are twice as many new cases. So a large part of the world is still seeing a lot of new cases, and that includes China, despite their zero tolerance policy. So looking at UK, the graph seems to have now truly come down. The new cases are nearly 60,000 from a 7-day average of nearly 76,000, encouraging. The United States, again, the graph has truly come down. At their peak, they had hit 800,000. And even though this is not the right thing or the time to say it, but जब हमारे 400,000 हो रहे थे, तब हमारे को we were getting a lot of bad press. India is mismanaged. India is shattering all records. India's COVID situation needs world help. But you know, we seem to have done okay. I mean, we are doing okay. And the reasons may be many, and I'll go into that in a bit. The reasons may be many. So, in US, there is a lot of polarization around COVID vaccines, COVID management protocols, and the CDC and the FDA communications are sometimes landing perfectly fine and sometimes not landing so well. Whereas in our country, the communication has been clear, uniform. The population is relatively young. US is the obesity capital of the world, and the average age is around 40, 41. India is a young country of 20, 21. All these factors may have played a part, but that 400,000, that seroprevalence of 70 to 80% gave us some level of immunity. Now, even though Omicron is evading immunity from vaccination and previous infections, I've been saying this for the last few weeks now, that it's not the virus that kills you, it's the hyper reactivity to the virus that kills you. So maybe this immunity, this recognition, whether from previous infection or from previous vaccination, has made the clinical course a little milder, enough for people to not probably test as much. With our population size, if we project from US, तो US की population और उत्तर प्रदेश की population comparable है. So if we look at, I think this should be Uttar Pradesh. Yeah, if we look at Uttar Pradesh, we are talking about what? About 20,000 new cases, and they are talking about 800,000 new cases at their peak. So reasons may be many, but we seem to have done okay. As you see, the tracker is showing that our new cases are significantly following a downward trajectory. The active caseload is still going up because the recovery will take time. The reporting is like that, but the recovery here you see is going down. So this is a trend that we need to watch. The deaths definitely has gone down. If you look at our 4 cardinal states that we look at, Maharashtra, 7-day average, nearly 7,500 new cases, 5,500. You look at Kerala, 7-day average, nearly 25,000 new cases, nearly 15,000. Look at Uttar Pradesh, as we just said, 7-day average, 2,300, and new cases, nearly 1,700. Where is Delhi? Delhi, if you look at it, the new cases 977, nearly 1,000, 7-day average 1,240. So everywhere the pandemic seems to have turned its corner. This was the Sutra model that was developed by IIT Hyderabad and a few more technical teams. The yellow is the model computed data. And the actual data is what you see peeping through this blue line. So it is very closely following the model. And according to this model, यहाँ पर थोड़ा सा graph has become steeper, but even so, if we project it somewhere around 20th of February, if it continues to follow the model, then somewhere around 15th of March, we can say that this wave is also truly over. So what is Omicron doing and why was it called the variant of concern? So we all know that there are a lot of mutations on Omicron, more than 50 of them being on the spike protein, but the clusters that made Omicron what it became are 3. 4 mutations, cluster 1, which were exposed when the spike opens up to grab the human cells. So this helps Omicron latch on more tightly than the previous variants. The second cluster is the cluster which allows the Omicron to bind more tightly to the ACE2 receptor. And the third cluster here is the one that allows it to fuse more easily with human cells and infect them. So its ability to infect is much higher. It is good fortune maybe of humanity that it picked up a common cold gene and hence infects upper airways with greater efficiency than lower airways. So the clinical picture is not as sinister as we have seen in the previous waves, but for everyone who has suffered it, पता लग जाता है कि ये हो गया है. So it's not a mild disease in as much as that is concerned. The second reason for concern is that as high as 10% reinfection rate. So even though the clinical picture is sort of milder, the numbers are huger and its ability to cause infections and reinfections very high. Looking at it in terms of what has happened. So if you see that Delta ke time vulnerable population kitni thi, the red is high risk non-immune population. The blue you can see are the ones which are low risk which are either previously infected or vaccinated. So the substrate of high risk non-immune population available for infection is much higher in the Delta wave. The disease is much more clinically sinister in the Delta wave. As you go through vaccination and also previous infection from Delta, you see that the percentage of population that is now at high risk, which is non-immune, has decreased. So if a variant that is capable of evading immunity causes infection, and we're not talking disease here, we are saying infection, causes infection, and there is already some immune memory to help fight that virus, the disease would tend to be slightly milder. Just because we are immune competent individuals who have some immune memory of the virus. If we look at it on the Delta front, A, the virus did not have immune evasion. B, there was a high risk population available. So it infected people who had no immune memory, or it infected those who had a defective immune response. So the clinical picture was also more severe. So is it really that Omicron is a much milder virus, or is it that our body is now beginning to understand the virus and not going into the hyperreactivity that we have seen in the previous waves? So हम बार बार वो वाला ग्राफ देखते हैं जिसमें this is the viral replicative phase, this is the hyperimmune phase, and this is the phase of thrombogenesis and deterioration. So that happens when the virus is not recognized by the body and the body responds to it with all guns blazing and causes a clinically more severe disease. अगर हम parameters देखें, what are the labs that are associated with severe and critical COVID? So leukocytosis, lymphopenia, neutrophils rising, eosinophils falling, and the NLR rising, we have seen in all waves. Hemoglobin showing a slight drop, red cell distribution width showing a slight rise, mean platelet volume slightly increasing, we've seen in all the waves. The CRP has risen in all the waves. IL-6 now is showing that it is not rising as high as it has in the previous waves. But in the severe cases, the panel stays the same. So even though the platelet counts are falling, the mean platelet volume is rising. Fibrinogen is rising. So the D dimers are rising. I'm going to introduce another very interesting parameter that we can follow. Albumin is falling, which is a negative acute phase reactant. So acute phase reactants, the positive ones are C-reactive protein, which can go as high as 1,000-fold rise in case of certain bacterial infections and sepsis. Fibrinogen, complement, parts of complement, and serum amyloid. Negative, these are the ones which go down. So albumin, transferrin, antithrombin, these are the ones which are going down, which still are going down in Omicron. So what happens with mild to moderate COVID is the leukocytosis will still be seen. It'll be a largely polymorphonuclear response. Lymphocytes will show a mild to moderate fall, LDH will rise, and albumin will fall. So the fibrinogen albumin ratio will get altered, and this will rise. As we go towards severity, the other parameters also tend to become much worse. If this carries on, either it can, with other complications, comorbidities, superinfections, come to non-resolution, or the body can begin to improve and recover and move into survival. So biological markers for screening, triage, and prognosis. We are now looking at connecting the dots as the disease is moving in a patient and in a population. So in the acute viral phase, the routine tests might be normal. There might only be mild lymphopenia. And if that is so, we will largely not even discover a lot of Omicron, nearly 80% of the Omicron. If it becomes mild to moderate, the lymphopenia increases, D-dimers, LDH, hypoxia, as yet we haven't seen with Omicron, but there may be hypoxia at cellular level, which is what we are going to come to in a bit. So the hypoxia at cellular level may happen because this is causing mitochondrial dysregulation. COVID is causing mitochondrial dysregulation. As it becomes severe, all parameters get deranged, and in the critical phase, there is elevation of inflammatory markers, and there is progressive cytopenia and immune exhaustion. So why is it that it causes hypercoagulability in all its variants? How is it that it causes cellular hypoxia in all its variants? There is increased blood viscosity and RBC aggregation in patients with COVID-19. This paper covers the previous variants, but the pathogenetic mechanisms stay the same, because we do notice these changes even in Omicron. So this study, and I'm quoting from the study, demonstrated that patients with COVID-19 had increased blood viscosity despite lower hematocrit, as well as increased aggregation. Now, this is aggregation and rouleau formation. It is not agglutination. In vitro experiments demonstrated a strong contribution of plasma fibrinogen in this RBC hyperaggregation. The aggregation correlated positively with clot firmness, negatively with clot formation time, and positively with the length of hospitalization. So we are talking about previous waves, but if you see the RBC changes, which Sir had pointed out earlier, are causing a change in the rheologic properties of blood. So what is the hyperviscosity and what is the RBC story in immune microclotting that we are beginning to hear of now? And not now, because मैंने आपको दिखाया ये तो March 2022 से चल रहा है. There are some studies which came out in August. There are some studies which came out a little later. But last week, Dr. Pretorius' study showed significant changes even in South Africa, and she called them microclotting. So blood viscosity in COVID-19 patients is higher than in controls, despite lower hematocrits and normal deformability of RBCs. Fibrinogen is increased, and this drives the hyperaggregation of RBCs. This is a true aggregation, not agglutination. Fibrinogen and aggregate sizes are directly correlated. Fibrinogen concentration is directly correlated with the strength of such aggregates, and snake venom anchored in plasma decreases aggregation. The hyperaggregation is directly correlated with enhanced coagulopathy, and hypercoagulability, increased viscosity, and RBC aggregation are directly correlated with markers of severe COVID. Now, at one level, we can say कि अगर सब में हो रहा है और हमने सब में देखा नहीं तो क्या होगा? So, nearly 50% of patients land up with features of long COVID. There are some cells which are mediating these. Those cells we have seen could be RBCs, could be monocytes, could be some other cells that we will examine now. So what is the role of monocytes in this aggregate? Now, when the innate immunity results in infiltration of the local tissue with innate immune cells, neutrophils, monocytes, and the rest, it causes formation of neutrophilic extracellular traps. These traps trap COVID-19 fragments and fragments of cells which are damaged by the virus. These are then phagocytosed by monocytes. So the circulating monocytes, which are CD16 positive, and spike protein fragments, which are in those extracellular spaces, form immune complexes. The circulating monocytes, which are recruited into the site of injury and or infection by CCL2 and CX3CL1. These are the things that we were talking about when we were talking about grantees and anti-HIV drugs, Meroveric working on long COVID. The monocytes are involved in the uptake of antigen, of presentation of this antigen in the lymph nodes, and also stimulating tissue repair. And as they mature into resident pro-inflammatory macrophages in the target tissue, they cause some local damage also. So the macrophages and the dendritic cells are the connection between the innate response of the monocyte to the local site, and are the connection with the adaptive immune arm in the body. These are relatively long-lived cells. So if they are loaded with the S1 fragments, the spike protein fragments, and if they land on the RBC aggregates with fibrin, with decreased albumin, which would otherwise be an antioxidant to mop up the clots, these microclots come into circulation and cause increased viscosity of the blood. What are the clinical implications of these? So these are those neutrophil extracellular traps with fibrin, with von Willebrand factor, with platelets, there is then activated complement system, and there is activation of the intrinsic pathway also. The factors that increase and decrease monocytes are fairly simple. So if there is an inflammation or infection, as will happen with the SARS-CoV-2 virus, the monocytes will increase. That is the innate immune response. If somebody is obese and has more circulating leptin, the monocytes will increase, and hence the inappropriate monocyte response will be more. In menopause, monocytes are higher. In andropause also, monocytes are higher. Growth hormone increases all white cell counts. The arm which allows us to have better innate immunity, as well as the arm that might go towards chronicity. So if you're looking at the blue column, what is it that is in your control to decrease monocytes? Regular, moderate exercise decreases monocytes directly. It also causes weight loss and control of obesity and a decreased concentration of leptin. In menopausal ladies, hormone balance and replacement therapy tends to decrease monocytes. Omega-3 fatty acids tend to decrease it. And in some cases where infliximab therapy has been given, also the monocytes decrease. These have been the strategies to manage long COVID. But what is it that happens with albumin? Now we can do either fibrinogen albumin ratio, or because we have been doing the CRP in almost everyone, I assume everybody is doing it, and we have been doing liver function tests in most people, we have albumin, and we can do CRP albumin ratio. A CRP albumin ratio of less than 1 is associated with best outcomes. A CRP albumin ratio of 1 to 3 shows significantly rising disease severity. If it is between 3 and 6, the change from the previous lab is not very marked, but change from the first lab is relatively marked. And if it is more than 6, the 100% patients of CAR more than 6 have severe disease. So it is a marker of severity. CRP albumin ratio is a marker of severity. If we look at 30-day survival, agar this blue line is nearly 100% survival, this line belongs to CAR less than 1. That means CRP is under control and albumin is high. Albumin is not falling. And if you look at the red line, the survival falls to nearly 40%. If you can see it more clearly here, the patients with just albumin of more than 32 grams per liter have higher survival rates than patients who have less than 32 grams per liter. So just one reading of albumin may give you cumulative survival prognostication. But why are these microclots happening? So probably there is a degree of endothelitis. Why does endothelitis happen? Endothelitis happens because there is direct viral infection of the endothelial cells. There is diffuse endothelial inflammation. There is an acute inflammatory infiltrate. There is an extracellular reaction. This is driven by and accompanied by the TNF alpha and the interleukins, which do activate the JAK-STAT pathway, causing apoptosis and pyroptosis of endothelial cells, hence causing a defect. Now, this defect makes the endothelium more sticky. And we have seen that the blood rheologic properties are already different. So the blood is also more sticky, and hence microclots are formed. But what happens to the platelets in this case? So now we have seen RBCs, we have seen monocytes, we have seen endothelium, we have seen albumin, and now we are seeing the fifth thing, the platelets. We have been saying that the platelets are immune activated in COVID. What are the markers which tell us that this immune activation is happening? So there is formation of immune aggregates with mitochondrial dysfunction, which affects antigen presentation and protein presentation. The ACE2 is not recognized by the RNA or the proteins in the platelets. So this is independent of ACE2. Even though ACE2 is what is the preferred pathway for the virus, in the immune activated platelets, this is not so. It is independent of that receptor. There is increased P-selectin expression, and the circulating platelet neutrophil, platelet monocyte, and platelet T cell clusters are all increased. What happens with the presence of these clusters is that the mannose activated arm of the complement and thromboxane arms of clotting are activated. And interestingly, even though platelets do not have ACE2, SARS-CoV-2 N1 gene has been found in platelets. Now we come to the sixth factor that could be driving, whether it is these microclots or it is the long COVID pathway or it is the chronicity or whatever we choose to call it, mast cells. The mast cells can either form the pro-inflammatory M1 category in the presence of TNF alpha, IL-1 beta, IL-6, IL-8, etc., 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 or they can stay as activated mast cells, which are releasing chimases, tryptase. The MCAS, mast cell activation syndrome, is marked by hyperreactivity to otherwise normal and well-tolerated stimuli, usually seen in females, usually seen in active individuals, may show emergence of new atopy and new allergies. So if there are so many things which are causing the blood to become more sticky, for microclots to form, for inflammation to persist, where all does it have its impact in the body? So this was an interesting study that was done, and which shows that the excess burden of COVID on cardiovascular health of populations. And this was done in nearly 5 million people in the US. This was done by on US veterans. And they found a nearly 300-fold rise in any major cardiovascular outcome. So, what is the long-term cardiovascular disease risk? There is a significant spike protein S1 immune complex mediated, probably microclot related risk of long-term cardiovascular disease. The risk of stroke has a hazard ratio of 1.5 at 12 months, which means it is 1.5 times more common in people who go undetected at 1 year from COVID than those who take adequate treatment. Dysarrhythmias, atrial fibrillation 1.7 is a nearly doubling. Sinus tachycardia, which we have seen, even I have seen sinus tachycardia, sinus bradycardia I have seen, ventricular arrhythmias, atrial flutter, all these are possible around 30-day, 6-month and 1-year mark, and the graphs are all here. Pericardial or myocardial inflammation. So pericarditis is nearly double, 1.8 hazard ratio, and myocardial inflammation 5 times, 5.3 hazard ratio. Ischemia and or infarction, nearly double, 1.6 hazard ratio. This might be what drives that 30-day risk of MI. Thromboembolism, which causes deep vein thrombosis, pulmonary embolism, as well as superficial venous thrombosis in the lower limbs, is common and is of the tune of double. So the spike protein itself is enough to cause coagulation and thrombosis by competitive binding with our own immune system and clotting pathways. The persistent clotting of the long COVID is accompanied by increased levels of antiplasmin. And these are the studies that Dr. Pretorius has released in the last week. Are they significant? If nearly 50% of the patients land up in long COVID syndrome, then these studies do become significant. We need to pick up each of those things. We need to pick up an abnormal red cell distribution width. We need to pick up monocytosis. We need to pick up MCAS. We need to pick up increased platelet distribution volume. And see in the long term that the rheologic properties, I told you that this is an aggregate and not a true agglutinate. So if we can improve the rheologic properties of blood, if we can improve the flow of blood, then these microclots will eventually dissolve. The interesting thing is that anti-phospholipid antibodies are raised in nearly 100% of patients who land up with microclotting and chronic COVID or long COVID. Anti-phospholipid antibodies are what drive autoimmune disease. So is albumin then a safe and ready reckoner for us? Is fibrinogen an important marker for us. Now, under normal physiologic conditions, albumin provides abundant free thiols to scavenge the reactive oxygen species. But under oxidative stress, albumin itself gets oxidized, and this is irreversible. So not only is it unable to prevent tissue damage, but actually may amplify tissue damage. This triggers the neutrophil extracellular traps and the inflammatory or thrombogenic cascade. So what is the risk stratification? How can we mitigate the risk? There are 4 levels of doing it. Behavioral, we have all been saying, hand washing, social distancing, mask wearing, no compromise till we can say that this is truly over. Even when the mandates go away, in high risk situations, what you do as an individual determines what every brick of the population wall creates for the persistence or finishing end of the pandemic. General health of the population. Obesity is a big red flag. If we haven't yet understood that we need to take care of population health at large scale, we never will. So, the World Yoga Day, yoga clubs, we should be promoting moderate activity at all levels. Demographic. If there is occupational exposure, if there is, we need to improve the coverage of our healthcare professionals, of our frontline workers. We need improved access to healthcare, which should be prepared to deal with emerging pockets of an epidemic when we declare the pandemic over. And educate. What are the biological factors? India is a young nation with relatively uniform messaging, and it's not as if in India we are not polarized. There is immense polarization here also. लेकिन जो हमारा mindset है, अगर हम अपने भारत के mindset को देखें, तो it is largely vagal mindset, largely accepting mindset. Huge populations have to work pretty hard to put food on the table. So active भी है. रिक्शे वाला अगर कोविड पॉजिटिव हो जाता है तो वो पता भी नहीं लगता कि होके निकल गया, because he's not obese, because he doesn't have leptin, because he doesn't have inappropriate macrophages, because he does not have monocytes which will react. So biological factors are also going to drive the risk and mitigate population risk. So if we were to summarize everything that we have done today, जो सर कहा करते थे ना, COVID-19 is a hyperimmune, hypercoagulable, manageable viral illness. The things to watch are, if you are getting a CBC done, don't miss RBC indices. Don't miss platelet and mean platelet volume. Don't miss monocytes. The altered viscosity and rheology can be a factor of endothelitis, which can be mapped with albumin, whether we do it as CRP albumin ratio or fibrinogen albumin ratio. We must be mindful of comorbidities. How are we going to, when we say that whatever it is that we have is what we should use to mitigate the risk and the disease, then exercise improves rheology of the blood. How does it do that? It improves even deformability of red blood cells, oxygen uptake. It improves the number and function of mitochondria. It increases endorphins. it improves vascular tone and reactivity and lowers blood pressure. But apart from these other factors, which kick in when the exercise hits a moderate level, there is increased plasma volume, which it is assumed is because with, like in running, with every thump of the foot on the ground, the plasma volume increases and the RBCs become more flexible. And there is auto dilution. So there is improved blood flow. What are the markers of blood viscosity? Can we predict them? And can we use then this new information that we have to guide our patients when and how much to exercise? So I think it is possible. This is just my thought. I don't have any studies to prove it, but logic says that we should be able to. So when you see that RBC concentration and plasma viscosity are indicating thick blood, you can start aspirin, monitor these parameters. You can encourage patients to pace their exercise and test for blood thickness using albumin. Maybe use CRP albumin ratio, maybe use fibrinogen albumin ratio, because proteins form a large part of the plasma. There are some natural blood thinners: turmeric, cinnamon, chili peppers, ginger, and all these are present in our kitchen. All these reduce RBC aggregation and increase RBC deformability despite shear stresses. So it is in our hands to do that. There is only one more thing that I want to show you, and that is, if I can show you the sutra modeling. Here. So this is the sutra model for India, COVID India predictions. This I showed you in the presentation, but interestingly, this is what, this is from IIT Kanpur, IIT Hyderabad. So look at this. This is the India model, where predicted was this yellow line, model computed was the orange line, and the actual data is the blue line. This is Mumbai. So the actual data is actually less than the model computed data. All cities they have done, all major cities. Delhi, Mumbai already down, Delhi already down, Jharkhand, Maharashtra, Punjab. So, they've done a very good job, and we expect this to get over by 14th of, so we expect it to get over by the end of February. Thank you. I think I have to give a, I want to give a special thanks to Dr. Advani, who put me on this path. He called me 3 days ago and he said, what about microclots? And I have been reading about it, and I thought, so if he's here, I would like to specially thank him. If he's not, then I'll thank him on the group. Yes, it can be because of dehydration, but I noticed कि Omicron के साथ, क्योंकि गले में scratchiness होती है, तो लोग पानी बहुत पीते हैं. But yes, it can be because of dehydration.
Dr. Nidhi,
जी sir.
What do you think about removal of masks? जैसे कई countries ने ऐसे कहा है कि मास्क पहनने की जरूरत नहीं है.
सर मैंने कहा ना रिस्क स्ट्रैटिफिकेशन है. अब जैसे अगर हम दिल्ली को देखें तो दिल्ली में इस वक्त पॉजिटिविटी रेट इज लेस देन 2%.
Yes.
तो अगर हम ये कहें कि मतलब व्हाट आर द ऑड्स दैट यू आर गोइंग टू मीट समबडी हु इज पॉजिटिव इफ it is less than 2%, but this is not the true value.
Yes.
Because so much of it is asymptomatic that it could be easily 10 to 20 times as much. So what we should be looking at is कि अगर हम जैसे ये गाड़ी में अकेले बैठे हुए हो तो भी मास्क पहनना है, that is stupid.
Ridiculous. Yes.
That is stupid. But अगर आप कहते हैं कि आप एक मेट्रो में हो और उसमें there is enough number of people. I mean, even if there is 50, there is and with the present figures, there may be a chance to have one exposure. लेकिन फिर भी it should be left to your discretion. Maybe mandates are not needed because seroprevalence will have hit 90% now. Probably more. So mandates may not be needed.
मुझे तो अब क्लिनिक पे भी N95 पहनना बड़ा मुश्किल लग रहा है. फेड अप सा हो गया हूँ. ट्रिपल मास्क काम करेगा?
बिल्कुल करेगा सर, बिल्कुल करेगा.
स्विच ओवर कर लें मतलब.
हाँ मतलब कर सकते हैं. और ये देखिए कि आप अब जैसे अभी तक हमारा वो प्लास्टिक कर्टन नहीं उतरा, हमारे अभी भी है, तो वो प्लास्टिक कर्टन भी है और आपको इम्यूनिटी भी है और वो कैरी ओवर भी कर रही है पिछली वेव से. तो मतलब मेरे को कोई बहुत ज्यादा डरने वाली बात नहीं लग रही है, लेकिन मैं ये नहीं कहूंगी कि धड़ेले से कहीं भी जाओ और कुछ भी करो.
हाँ वो तो ठीक नहीं है.
हाँ वो ठीक नहीं है.
डॉक्टर निधि, आई हैव अ क्वेश्चन.
जी मैम.
दैट in long COVID, if all the parameters of viscosity are raised or dearranged, then what do you advise besides this ginger and natural?
Ma'am, blood thinners, but एक ना बहुत
blood thinners में ये इकोस्प्रिन और साथ में फिर रिवॉक्साबेन वगैरह तो नहीं देना?
नहीं. Rivaroxaban is not going to work on this because these are not true agglutinates.
Okay.
It's not going to work. But there is a very interesting, और ये मतलब ये because I am more into fitness, I'm telling you this. जब हम फिटनेस की बात करते हैं और हम कहते हैं एक्सरसाइज करो, तो हम लोग ड्यूरिंग द एक्सरसाइज सेशन भी डिहाइड्रेट होते हैं.
Yes.
Whether it is sweating or it is mouth breathing or it is whatever, we do get dehydrated even in our fitness sessions.
Yes.
So hydration itself, matlab if you drink adequate amount of water, which is 3 to 4 liters a day,
okay,
it improves the rheologic properties of the blood. It decreases the viscosity of the blood. So it's a very simple thing.
What about lemon water? Lemon water with salt.
जैसे भी मैम फ्लूइड इनटेक आप improve करेंगे तो सारे एथलेटिक पैरामीटर्स इंप्रूव हो जाते हैं. Endurance till exhaustion. If you are hydrating, you can do more exercise. Aerobic working capacity. If you are hydrating, then you can carry on, sustain the effort for higher effort. If you VO2 max, your oxygen uptake is better and your heart rates are recover faster if you are doing proper hydration.
Okay. And how does this coenzyme help?
Mitochondrial dysfunction.
Okay. Thank you.
I have a question
and
observation. In this particular wave, we hardly had any cases who needed steroids or even who needed anticoagulants. What's the reasons?
Ma'am, the steroids were even in the previous waves needed only when we saw damming lung pathology.
Correct.
And
Oxygen and continued fever and
yes,
not
yes.
responding. But
Whereas
coagulants indicators were D-dimer and some of these, markers. But none of those also, I didn't see anything rising, D-dimer or.
yeah, so this thing about microclots is now making its way back into the mainstream के इसको ठीक करना है तो दे दो blood thinners. But these clots are not going to dissolve with the rivaroxabans and the apixabans. They require, so they're a function of viscosity and RBC.
So pani pilai or anti platelets are better, you mean?
Yes, 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 yes.
And the second question or observation is, I have recovered, say, as 7th day, 31st of Jan. Must be Omicron, and I have no knowledge of who was positive around me. I've been hunting that person.
Absolutely.
But none.
Absolutely.
So till now, I'm experiencing this. Deep in the throat, just above probably the larynx.
So am I.
Thing, what is it?
So am I.
Get rid of it.
So am I. So I feel this is a local response. It is going to take a little while. It's one of the minor chronic features, but it gets better. It's like kabhi hota hai, kabhi nahi hota hai. Like today, maybe I coughed only once. Last week I was coughing more often. And if we follow that last slide, exercise moderately, hydrate well, take care of and we ignore the factor of sleep, but sleep has a very good anti-inflammatory effect, very helpful in recovery. So good quality sleep, 6 to 8 hours. I think all these factors will improve outcomes.
Madam, I have my own question. I was to go for the cataract operation before 2 days. I do my CBC, and in the report it was found that there was leukopenia, lymphocytosis, and monocytosis. Monocyte count was 14.
Yes.
And CBC was normal.
Yes.
Then what is the reason?
So this is exactly what I've been saying. कि CBC जब हम कराते हैं, तो we should be looking at every parameter. So if your monocytes are high, and if you have any clinical features, even this, loratadine works better than cetirizine. You will need to block histamine, so that should be done at all levels. Even if you're not dizzy, take low dose beta histine. Even if you don't have acidity, take famotidine. And even if you are not having any obvious allergies, take loratadine or cetirizine, but take all three for a couple of weeks and see how it goes with you.
But my operation is okay now, and I am not suffering from any illness.
नहीं, अगर कुछ हो रहा है तो that's what I'm saying कि ये incidental findings हैं, but they are consistent.
I also asked the pathologist about this method, and this is the aging process, and you will see the slight rise of the monocytes during this age.
Which is also possible. As I said, testosterone and estrogen both are determinants of monocytes. That is also possible. But monocytes ka bhi, a mild to moderate exercise will bring it down. And if you have any clinical features, then you can add all 3 histamine blockers.
Yes.
Dr. Nidhi, I missed
ma'am.
out. What was the first thing you said? One is famotidine, the other is
Beta histine, ma'am.
beta histine में क्या आएगा?
Vertin.
अच्छा, oh.
That's H3. That's H3.
याद ही नहीं आया. वर्टिन याद रहता है, बीटा हिस्टिन याद नहीं रहता.
I've not seen this anywhere. I've not seen any studies, but I have seen that when I add Vertin 8 mg
Okay.
to famotidine and any of your anti-allergics, जो भी करने हैं,
हाँ.
तो clinical resolution is much faster because वो H3 को block करता है central nervous system में.
ठीक है, ठीक है.
So brain fog and all those things are not there.
Right, right. Okay. दिमाग से निकल गया बीटा हिस्टिन.
स्लीपीनेस इंक्रीज देखा है मैंने 3 केस में देखा है इंक्लूडिंग माय सेल्फ.
क्या
हाइपरसोम्निया तो नहीं बट फील लाइक स्लीपिंग. बोथ माय डॉटर, माय नीस, माय सेल्फ.
मैम आप कराओगे ना तो कुछ ना कुछ जरूर निकलेगा सीबीसी में, क्योंकि ये दिस इज वेल आई वोंट कॉल इट फटीग बट इट इज वेल ऑन दैट स्पेक्ट्रम.
बच्चों का तो नहीं कराया कुछ भी. अपना हुआ था. सीआरपी बढ़ा हुआ था. 6.4 HbA1c था. TSH reached 7. Normally it stays around 5 to 6. And HbA1c stays around 6.1. तो वो थोड़ा बढ़ा था. CRP 78 हो गया था. बट अब 8-10 दिन में तो कम होएगा. रिपीट
एक बारी रिपीट करके देखिएगा. अभी भी हो सकता है कि 10 के अराउंड हो.
तो बस फिर यही लोराटिडीन एंड फैमोटिडीन एंड
यस
चलो एक खा के देख लूंगी लोराटिडीन. ओके थैंक यू.
ओके
8-10 दिन के लिए कि और ज्यादा?
मैम मैं तो मतलब मेरे को जब याद आता है ना तब ले लेती हूँ, क्योंकि खांसी जब ज्यादा होती है तो एक ले लेती हूँ. आई एम नॉट टेकिंग इट रेगुलरली. सो आई वुड से दैट when I was following my CBC during my episode, I observed that my monocytes had also risen. Now that could be because of any of the factors that I have given here, but they fell to normal range as I resolved. When I got my exit CBC, everything was normal. So I think people who face more problems, which are like chronic fatigue syndrome or brain fog or tiredness, these people should try see for at least 3 to 5 days how it is feeling, because monocytes and macrophages are cells which are long lived, just like RBCs. RBCs are long lived cells, 3 to 4 months.
हाँ बिल्कुल.
Anything anti-allergic in masalas or Ayurvedic? You're an ENT person.
Ma'am, haldi.
अच्छा वही anti-inflammatory. हल्दी, अदरक,
yeah,
cinnamon. और एक और बोला था आपने anticoagulant.
चिलीज.
हाँ नींबू भी और पानी भी. आई थिंक
नींबू तो विटामिन सी है ना, तो एंटीऑक्सीडेंट है.
हाँ ओके थैंक यू.
थैंक यू ऋतु.
Thank you.
Thank you.
Thank you, madam.
Thank you so much. I think this group is causing me to read a lot. I hope it is of benefit to all of you also. And if there is anything that anybody else wants to do, we can have one of you do next week or the week after also. I would like to see if somebody's done with children anything. We can probably have a talk.
डॉक्टर निधि एक कल भी टॉक हुई थी, somehow I missed that.
कहाँ पर सर?
यही इसी पे ही हमारे ग्रुप पे ही आया हुआ था।
वो सर वो उनका ना जो सिमाओ का इंटरनेशनल
हाँ।
मेडिकल एसोसिएशंस का है ना,
हाँ जी हाँ जी,
वो सेशन था, वो हर सैटरडे को होता है सुबह 9:30 बजे. Dr. Pandit from Bombay had given a very good presentation on why Omicron is killing if it is mild. So it is there on YouTube. You can,
के बारे में था।
you can check it. It is there on YouTube.
मैं क्या आप क्रक्स बता दीजिए, क्या डेथ्स का क्या हमने बताया? मेरे ख्याल कोमॉर्बिड का ही होगा बस।
हाँ, डेथ्स का वही है कि कोमॉर्बिडिटीज हैं. लोग थोड़े केयरलेस हो गए हैं क्योंकि मीडिया ये नैरेटिव बिल्ड कर रहा है कि माइल्ड है. So those were the two factors that he brought about. He was also of the opinion that we shouldn't completely let go of COVID protocols. So that was it.
Okay. चलिए YouTube पे देख लेंगे उसको।
जी सर.
Thank you.
Thank you so much.
Thank you, ma'am.